So I'm not sure if you want to. Okay, that's fine. Okay, we can record. Sorry. Okay. So sit in a comfortable position. Keep the shoulders relaxed, spine erect. Let's start with easy pranayam. Arms to your sides. Exhale out completely. Inhale, arms up, palms together. Exhale, bring them down. Again, inhale, arms up, palms together. Exhale, bring them down. One more time. Inhale, arms up, palms together. As you exhale, bring the arms down and relax. Keep your eyes closed, spine erect, shoulders relaxed. And focus on your breathing. You don't need to change any of your breathing patterns. Just observe your breath. And completely relax the body. Relax the mind. Focus your attention to your breath. Visualize an image of the divine that you worship. It can be any god or goddess of any religion. Place that image between the two eyebrows. Look at that image. Completely surrender to the divine. And fill your heart with love and gratitude. We'll stay here for 30 seconds. And slowly open your eyes. We have a special guest today, special speaker, Dr. Vibhakar Karambelkar. He is a doctor of physical therapy. And I would say he is the best friend of all our seniors, all of us seniors. Because any kind of physical senior issues, he will be there to help us. He has given a talk on preventing the fall. We also had a session with at the Shiva Vishnu temple a few months ago. And in the beginning, there, he was saying that I don't want to give any talk. I will just, if anyone has a question, then I will answer. And he was just waiting there. And all of a sudden, a busload of people showed up, all seniors. And then we had to make special arrangements for him, and so some tables and people around him to give a so many people have questions, and he has the answers for it. So that was really very nice, Vibhakar. And Vibhakar has been practicing this for more than 30 years, and he has a facility in Annandale. In case you are in this area, please visit his facility. It's I did go there once, and it's a nice facility, and any kind of physical therapy related equipment is there, and he's there to help. So Vibhakar, again, if in case I missed something, please help you and just introduce yourself. And so I enjoy this session. Thank you very much, Vibhakar, and welcome.
Thank you, Sabnis Kaka. Good morning, everybody. Namaskar. Thank you for the nice introduction. And I have been given this opportunity with Shri Yoga, and the credit goes to Shri Sabnis Kaka as well as Alka Deshpande. And I will try my best to keep bringing some topics that might be useful. So, Thank you for the nice introduction. And with this, can we begin?
Yes. Yeah.
So I'll share the screen. So today, our topic is osteoarthritis of the knee. Most people know what is osteoarthritis of the knee, and there is a lot of information out there, and people are very well aware of this condition. The purpose of this presentation today is to basically bring you some useful information in a concise manner. So, as we all know, actually this, okay. So as we all know, knee osteoarthritis is a degenerative condition of the knee, meaning that the common understanding is that the cartilage of the knee is damaged during the process of this disease, and it causes pain and stiffness and difficulty in walking. But it is not just the cartilage. It is the bone as well as the soft tissues surrounding the joint. So which could be the ligaments, which could be the joint capsule, and the menisci in the knee as well as the cartilage. So any progression of the disease eventually will affect all of the soft tissues as well as the bony ends. But sometimes it is the damage to these soft tissues that will eventually lead to osteoarthritis. So that is what we have to remember. So during our early age, in your 30s and 40s, if you hurt your knee, then the likelihood of getting osteoarthritis later is quite high. So there are many people afflicted with this condition. There are about 14 million Americans who are suffering from symptomatic OA. The reason we call it symptomatic OA is there might be hidden OA changes going on in the knee without causing any symptoms. So these are just the people who have the symptoms. And you will be surprised to know that 2 million of them are younger than 45 years of age, and about half of them are less than 65 years of age. So we cannot say that osteoarthritis is a condition of somebody who is older of age. So it can happen to really anyone. So it causes a lot of psychological stress, disability pertaining to your life and work, and overall poor quality of life. You will also be surprised to know that among the Indians in India, the incidence of osteoarthritis of the knee is 15 times more than that of the Western countries. So in fact, we tend to believe that Indians in India are more physically active. They sit on the floor, they squat down, but why would that be so? So one of the reasons is vitamin D deficiency, which is very prevalent there. And then although you sit on the floor or although you are able to squat down, sometimes that leads to overuse and use of improper footwear. So that we all know that if your footwear is not correct, that incorrectly loads the knee and it could cause problems. The overuse happens when you assume positions, like if you sit in a cross-legged position for a very long time, or if you squat down and work at a lower ground level for a very long time, then that is considered overuse. So the economic cost is very high, and this is just the US, $85 billion per year. And one of the most common joints affected is, of course, the knee. So the other common joint that we often tend to overlook that is affected by the osteoarthritis is the joint at the base of our thumb in our hand. So that is another very common joint. So first symptoms of osteoarthritis in the body will appear at the base of the thumb, then it would be the knee, and then everything else. So who is at risk? Any woman over the age of 50 years is considered as a high risk individual for developing osteoarthritis, or irrespective of whether it is a man or a woman, any previous joint injury. So the joint injuries could happen during your school or college days. It could be like a meniscal tear, or it could be a ligament injury or anterior cruciate ligament tear. And it is given once you have that injury, even if it was treated successfully, that the person will eventually have early arthritis. So the other thing that happens in the knee over the years is that if you hurt your knee, then you naturally tend to load it less, and that underloading will itself cause increase in the risk. And then not to mention the genetic predisposition, you will get arthritis if you will if your parents have suffered from it extensively. So when you look at the knee, it's not just one joint. It is a complex of two joints encased in a joint capsule, in a single joint capsule. So the bone of the thigh and the bone of the lower leg forms the tibiofemoral joint. So that is our main weight-bearing joint. And then the other joint is the patellofemoral joint, which is part of the patella is part of the tendon of the quadriceps muscle, and it really acts as a pulley to allow the knee muscle to work on the knee more effectively. So that forms a joint with the femur, the lower end of the thigh bone, and that is called the patellofemoral joint. It is the patellofemoral joint that is the first to get involved in knee osteoarthritis. So the main weight bearing joint, as I said, the tibiofemoral, gets the brunt of the body weight. So higher the body weight, the greater the load and more the risk of arthritis. So when the body weight acts on the knee, there is a modified cartilage, which is called the medial and the lateral meniscus. These are like discs in between the two bones that distribute the load. And any damage to those discs will lead to arthritis. In the picture, you see an X-ray. It is called the skyline view or the sunset view of the patellofemoral joint. So here the person is lying on the back with the knees bent, and then a tangential view of the patellofemoral joint is taken, and you can see very clearly the roughening of the edges, obscurity of the joint almost grinding onto the bone with each other. So that is what typical patellofemoral arthritis looks like. So our knee is supported by various soft tissue structures. So the main out of that are the ligaments. You must have heard the names of these ligaments. The ligaments on the sides are called the collateral ligaments, which is the medial collateral and the lateral collateral ligament. They prevent the knee from sliding out sideways. So they hold the knee together so that it doesn't glide side to side or open on any one side. The medial collateral ligament is attached to the medial meniscus, which is the disc I was talking about earlier. So any injury to the medial collateral ligament can lead to the medial meniscus injury. Then the cruciate ligaments. So there are two of them which cross each other in the center of the joint. They are called anterior cruciate and the posterior cruciate ligaments. So what they do is they prevent the front to back translation and abnormal rotations of the knee. So any abnormal loading, any abnormal motion or injury that compromises any of these ligaments will eventually put the person at risk. And if the person already has osteoarthritis, then it will cause progression. So when you diagnose somebody with knee osteoarthritis, there are two ways. One is clinically and one is based on the X-ray. So the X-ray changes and the clinical exam doesn't really go hand in hand. They are not correlated. Meaning, if anybody has severe arthritis shown on the X-ray, they may necessarily not have a lot of pain. So right now, I treat somebody who has such severe osteoarthritis that the joint is completely bent outwards. Each time he takes a step, it just glides out to one side, and the joint is very deformed, but he has no pain. So he is completely non-compliant to use of any brace. He doesn't want to really take care of the joint at all. He doesn't even want to wear a soft knee sleeve just because he has no pain. So there is no correlation. So some people who present with a lot of pain may not have much changes on the X-ray, whereas some people who have a lot of changes on the X-rays will not present with much pain. So it is helpful to have an X-ray done early on to gauge the condition of the knee as a baseline and then track its progression. But you have to really treat the clinical picture. So what do you see on the X-ray is the joint space. So when the cartilage wears down, the joint space reduces, which is the black area between the two bones in the knee joint. That is the space that the cartilage occupies. And then because of abnormal loading, there is presence of lipping of the bone or spiking of the bone. So those are called the osteophytes. So these are the primary things we look for on the X-ray. So the bony spurs and the joint space. Clinically, when somebody comes to us with osteoarthritis, the diagnosis is based on, again, some criteria, which is if the person has an age of more than 50 years, the likelihood is there. There is morning stiffness or even nighttime knee pains, crepitus or cracking in the joint with active movement, pain on most of the days in the past month, tenderness at the joint line, especially on the inner side, enlargement of the knee, and any presence of pain when climbing stairs, especially climbing down. And then the point to highlight here with osteoarthritis is that there is no warmth of the knee. Unless there is a lot of soft tissue inflammation, the arthritis will not cause inflammation within the joint. And that's why nowadays they shy away from using the term arthritis, which indicates inflammation, and they call it osteoarthrosis, because that is a very characteristic feature of knee joint arthritis, is that there is no inflammation inside of the joint. That it could be outside, but not inside. So what exactly happens when somebody has knee osteoarthritis? So the symptoms are pain with activity, limited range of motion, joint stiffness, joint swelling, knee tenderness, feeling as if the knee might buckle, and deformity of the joint. So one of the main hallmark characteristic of knee osteoarthritis is deterioration of the cartilage. So the cartilage begins to deteriorate very early. As we age, our joint tends to get dry. So the lubrication inside the joint reduces. So if you assume one position for a while, all the lubricating fluid settles at the bottom and the joint is rendered dry. Then you suddenly get up and start moving, and then there is shear and compression force acting on the joint that will damage the dry cartilage. So that's why you have to make sure that if you have pain when you get up and start walking, and then it goes away after some time, it is best to first like move the knee in an unloaded situation before you put body weight on it to let the lubrication circulate and then start walking on it. So that's why they say that early detection is the key, because if you do exercises, you maintain good cartilage health, you maintain the joint lubricated, and then the risk of damage reduces. So early MRIs can have the ability to detect this change, is the ability to hold the water in the cartilage. So far I'm unaware of any kind of treatments that will prevent this from happening. They have done a lot of experimental treatments in NYU where they punch small holes in the cartilage to regenerate it, make it grow. And then they also do some injections of lubricating gel inside the joint, which we will talk about later. So this is an image of an arthroscopic view of the cartilage where you will see the fraying of the worn cartilage, and then there is a hole in the center which shows the exposed bone. So this is like a very severe condition of the cartilage. If the cartilage loss is about 60%, then they would generally recommend a replacement. So the other thing that happens in the knee osteoarthritis besides cartilage loss is impaired muscle function. So generally, like the cartilage tends to get dry early on before the symptoms appear. Similarly, the muscle weakness usually precedes the arthritis. So the loss of muscle strength eventually will cause reduced physical activity and then furthering the muscle loss. So you want to prevent the disability from arthritis. The preventative rehab should target muscle strength in people, any person over 50 years of age, and those exercises should be of resistive nature. They have also found out that people who have osteoarthritis have a muscle activation deficit, meaning that they cannot voluntarily generate enough muscle force on their own as compared to when a contraction is generated through use of electrical stimulation. Means their muscle will contract strongly in response to electrical stimulation, but not to their own effort. So this muscle activation deficit is usually due to disuse atrophy, pain and swelling in the joint, and greater muscle fat. So as a person ages, we tend to lose lean body mass, which is the weight of the bone and the muscle, and slowly there is fatty deposits happening in the muscle, and then there is loss of the basic functional unit of the muscle called the motor units. So that reduces the strength. So one of the most important things one can do is to increase the quadriceps strength, and that will reduce the activation deficit. So in addition to the activation deficit, there is also something called arthrogenic muscle inhibition at work. So when there is pain in any joint, the surrounding muscles are neurologically inhibited. So in order to reduce movement in that joint, our brain inhibits the neural connections to those muscles because of the pain. and that reduces the muscle force, that reduces the strength and speed, which is the power. So when that happens, and if it is not addressed, eventually the person gets used to it, and then they will walk differently, their balance will get affected, and then they could start falling. When we stand, um, the normal biomechanics of the knee are such that the line of our body weight falls through the center of the joint. But when a person develops arthritis, or vice versa, if when the person develops arthritis, the alignment could change, or if the alignment is changed, then the person can develop arthritis. So both ways. So if there is a varus, that is an outward bowing of the knee, or a valgus, that is an inward inclination of the knee, then the forces going through the knee are not going right in the center. They will pass through either one compartment or the other. And most commonly, it will pass through the medial or the inner compartment and cause excessive wear and tear of that particular cartilage. So when you notice something like that, you have to check for stability of the joint. And then we often recommend something called an unloader knee brace. Or if the person is not going to use the brace, then at least a cane in the opposite hand will make a big difference. So the joint biomechanics are also altered by the body weight. So for every 1 pound that is gained, there is a 4 times increase in the joint compressive force. So you can imagine a person who has a bow knee, that is a varus of the knee, the weight is passing through the inner compartment, it is excessively being loaded, the outer ligament is being overstretched, and they are going about their day-to-day activities and they are gaining weight. So on a knee that is being subject to so much of stress, if every pound is adding 4 more pounds of weight to the knee, how fast that arthritis can progress or it will cause disability. So they have shown through studies that women who lost weight had a significant reduction even in the risk of developing OA. So what do we do in terms of physical therapy? So when we get people with the diagnosis of osteoarthritis, we do a thorough evaluation because every person is different and their priorities are different and their clinical presentation is different. So, but in common, we look at clinical measures, self-reported measures, and performance measures. So these are the 3 areas we will assess them with. So what are we really looking for is muscle weakness. So we know that it's mainly the quadriceps that's weak. So we will be critically looking at the quadriceps weakness. Any joint tightness or contractures, the most common that we would encounter is knee flexion tightness. So that is stiffness on the back of the knee, the posterior joint capsule getting tight, or the calf muscles or the hamstrings getting tight. And that knee flexion tightness will put a lot of strain on the knee, increase pain, make them feel unstable and as if they might buckle. Then we will assess the joint pain, trying to quantify it by using pain scales and monitor their activity limitations. So when we look at the muscle weakness, we are aware that it is a primary predictor of poor physical function. And we have to focus on the quadriceps muscle strength. In addition to that, there is also hip abductor weakness and ankle plantar flexion weakness. That is the calf muscle weakness, and hip abductor, which means the muscle that moves the entire leg from the hip outwards. So if there is a hip abductor weakness, it puts a strain on the knee. It causes a valgus strain and also puts a strain on the foot and makes the foot go slightly as if going into a flat foot position. So these weaknesses are indicated to us by the way the person walks. So when we assess their walking, we can tell if the person has any hip abductor weakness going on or any kind of plantar flexion weakness going on. So the gait assessment is very important to see how all these weaknesses affect them and what is impairing their ambulation. So then we look at the joint range. We focus heavily on getting full extension at the knee joint because any loss of extension at the knee is an indication that the osteoarthritis is progressing, and it is an indicator that the person may soon require a total knee replacement if that is not corrected. So in addition to the knee flexion, we also would measure the varus or the valgus deformity, which is the bowing or inward bending of the knee. So as the cartilage gets thinner, the knee spacing reduces. And in end stage, it is bone on bone. That means the cartilage is very thin, the joint is very closely approximated, and the joint space grossly reduces. So as the joint space reduces, the ligaments tend to become loose. And then any laxity of the knee joint in a static position or in a standing position will cause instability. So you will see that when the person is lying, if the ligaments are loose, you can actually shake the knee from side to side. And when the person stands with such an instability, the knee doesn't stay straight, it just glides outwards upon loading. Then there is also functional instability that we look for, which is because of the poor muscle strength. So there could be buckling or any kind of gait deviations, walking impairments because of imbalance in the muscle strength. So basically controlling of this instability is very important. Although the person may not have pain and they are used to walking like that. So early bracing, even with a soft knee sleeve to provide support to those affected muscles and ligaments. And as I spoke about earlier, the unloader knee brace is quite important. The other area we look at is pain. So we are worried about the intensity of pain, frequency, and utilizing pain scale gives us like a quantified measurement of the pain. So when a person presents with pain, many a times it is not the pain arising from the joint itself. So most of the times we notice that the pain is arising from the soft tissues from outside of the joint. So the real arthritis pain that they experience that is coming from the joint is if they are walking and when they put weight on it and if they feel the pain that is from the joint, or if they are sleeping at night, the muscles relax and then the raw ends of the bone touch each other and then they feel night pain that wakes them up, that is from the joint. But for most part, many of the patients present with pain that has origin either in the muscles or attachments of the muscles around the knee or ligaments and other soft tissues. And all that pain can be properly addressed using physical therapy. And if that pain is reduced, then they get a clear picture of how much the joint pain is bothering them and then their function improves. So the treatment of pain is very important. because that sets the stage for further strengthening and stretching and addressing the functional issues. The other area we have to look at is the joint effusion. Sometimes the swelling is from the joint itself. So if the joint itself is the cause of the swelling, there is fluid inside the joint, and that will cause more pain, more instability, and it will cause further muscle inhibition. Sometimes the swelling is not from within the joint, but it could be in the soft tissues as local swelling or puffiness, and then that can be treated with the therapy modalities. So, in addition to these clinical measures, we look at self-reported measures. So we utilize something called a lower extremity functional scale, which is patient questionnaire. So during the assessment, we may or may not give an actual questionnaire to the patient, but we will ask those questions and fill it out for them. And that gives us a baseline score to quantify the disability. And then that helps us to track progress and report it to the insurances that, okay, the score over a period of time has changed, that is significant, and the person is progressing. Then in addition to that, we do like some baseline tests. So this is something that anybody can do for themselves also. Number one is the 25-foot walk test. So you mark a distance of 25 feet and then walk at as fast as possible, but as safely as possible. And note how many seconds it took you to do that. So generally, the norm would be 5 seconds or less. If you take longer, that means you have some issues with the muscle strength, balance, or pain, or any of that kind. Then the second test is a 30-second chair stand test. So you start from a chair, and with a timer set for 30 seconds, you do sit to stands. So if you can do 19 or more, so that indicates good lower body strength, and anything lower than that indicates that it's a warning sign and you need to strengthen the lower extremities. And then we do another test called the timed up and go test, where person sits in a chair, then they get up and walk a distance of 10 feet, turn around, come back and sit down. So here we check how quickly they are able to do that, how they are able to get up from a chair, initiate ambulation, accelerate, quickly change direction, come back, decelerate, and then turn around and sit down. So it tests a lot of areas like transfers, walking speed, and there are norms for this test where any score above 15 seconds indicates a risk of fall. So even though the person may appear to be fine, but if they take longer than 15 seconds to do this, they are considered as fall risk. So now I found this interesting. You say the pain in my left leg is caused by old age, but doctor, my right leg is just as old and doesn't hurt at all. So that clearly tells us, and this is in reality the case, like one knee might be more affected than the other. So it tells us that it is not a condition primarily affecting people who are older, but it can happen to anyone. So in terms of treatment, we will target the pain and stiffness. We will work on prevention to slow down the progression. Although the structural damage cannot be reversed, but we can improve their functional status, reduce the risk of decline, in fact, reduce their pain, improve strength. So we will be also focusing on improving the physical strength and physical activity. And we strongly recommend, if the person is posted for physical surgery at any point, we strongly recommend preoperative physical therapy, because we have seen, and it has been shown through research by Medicare, that prior to total knee replacement, people who did preoperative physical therapy, where we teach them all the exercises and strengthening activities that they are going to do post-op, if they are well conditioned prior to the surgery, and if their pain is sort of controlled prior to the surgery, and if they are aware of their exercises beforehand, their outcomes are much better. So generally people think that after surgery, they are just going to feel perfectly fine, which they do initially because the painful joint has been replaced. But then the recovery for the surgery is 4 to 6 months, which sometimes comes as a shock to them. But if they have done preoperatively therapy, then their recovery is much shortened. And then again, the post-operative physical therapy is quite important. So we already talked about this. The muscle weakness is from disuse, neuromuscular activation deficit, muscle inhibition due to pain and swelling, and uh, changes in the muscle as the person ages. So it is really very important to emphasize exercise targeted at muscle strengthening. So they have shown through research that land-based exercises result in the most improvement in pain and function, but the aquatic exercises are also very important. Some people follow aquatic regimens, and it is really helpful in people who have pain. If the pain is their presenting symptom, and then any kind of exercises on land will give them more pain and cause them more discomfort, they will generally tolerate aquatic exercises much better and will benefit absolutely. So once you go through a physical therapy program, the benefit will last for about 6 months. But if you follow the home exercise program on a daily basis, then the benefit will continue to be with you. So the two main classes of exercises are stretching and strengthening. In addition to that, stationary recumbent bicycle, whole body vibration, aquatic bicycling will improve pain, strength, joint lubrication, as well as function. So the exercises could be on land or in the water. They can be open or closed chain. Open chain exercises are, for example, person sitting in the chair as in the picture and have a weight around the ankle and extending the knee. So that is an open chain type of exercise where the end of the extremity is unsupported. And a closed chain is where the end of the extremity is in contact with something. Like, for example, if you are doing a squat, or if you're doing a leg press, or you're doing a bicycle, your foot is attached to something. So that is called the closed chain exercises. And the closed chain exercises are always safer to do when you have pain in the knee rather than open chain, which causes angular stress at the joint. So the exercises should be progressed in intensity, duration, resistance, and repetitions. So if you do the same exercise all the time, it will lose its effectivity. So you have to make some changes to it. You don't have to change in all the areas, but any small change to it will keep the muscle working harder. And there is a lot of research backing the fact that strengthening exercises help in the OA of knees. And as a rule, in order for better health, anyone over the age of 50 should engage in resistance exercises in a safe manner, not to get injured, but even if the resistance is light, that is really very strongly recommended for general health. And then they say that eccentric exercises are more beneficial. So any exercise has two components. One is the concentric, like for example, if you're lifting a weight, like lifting a dumbbell. So when you lift and the ends of the muscles are coming together, that is called concentric. And when you lower the weight, where the muscle is lengthening as you put the weight down, that is called eccentric. So the eccentric type of exercises are always more beneficial in terms of strengthening effect. So when you do any kind of exercise with weight, it is important not to rush and lower the weight slowly and not let gravity take over. And then we often augment the exercise with electrical stimulation. It is called neuromuscular electrical stimulation. So that will produce a higher contraction in the muscle. So, and there are studies to back that when we use neuromuscular electrical stimulation, it not only strengthens the muscle, but also helps with the pain. Then we use other modalities such as TENS, ultrasound, heat or ice packs. But these modalities are to be used in conjunction with exercises. They are not like going to be helping you in the long term as a standalone modality. It is the exercise that really makes the difference. And then among all of these modalities, TENS is considered like low cost and high value. And we always recommend people that they can use it at home if they have pain interfering in their function on a daily basis. So these are some examples of the stretches that you can do for the knee. The most important is to stretch the knee to make sure that it is fully extended. So the first stretch here is the stretch for the posterior knee capsule. So there are yogasanas which closely mimic that. This exercise is actually based on those yogasanas. And then if you see the other two exercises, those are targeting flexion of the knee. So this is also based on yogasana. So once you are done with the exercises, the other area of treatment is bracing. So when there is instability, as we talked about, varus or valgus, hyperextension or knee buckling, so some form of bracing to improve the stability, improve the alignment and loading is very important. So the picture here shows the medial compartment unloader brace that we talked about earlier. So it works on a 3-point principle and it effectively unloads the medial compartment, which is most commonly compressed and under heavy stress in knee osteoarthritis. In lieu of this, like even a soft knee sleeve will really work wonders. Some other treatments, for example, weight loss, as we know that it significantly affects the joint loading. So it will certainly be of great benefit to lose whatever small amount of weight that anyone can. Physical activity, there could be a misconception sometimes that if you walk too much, that might make the arthritis worse. But that is not really related to worsening of the osteoarthritis or even further damaging the cartilage. In fact, walking is really beneficial if you have knee arthritis. The thing that will damage the cartilage further is jogging, running, jumping, or any activity that will cause you to suddenly change direction, twist, or turn. So they have said that for prevention of functional decline, at least 6,000 steps a day is essential. And that is the target for the knee osteoarthritis patients. So minimum 6,000 steps a day. But most of our seniors that I come across, they are very uh, good walkers. They do target up to 10,000 steps a day, and then you can see it in their health. Some other treatments that are quite common are knee joint injections. They relieve pain and inflammation. So if you go to a pain management doctor, that's what they will recommend. So the injections could be basically corticosteroid injections, which will give you immediate effect. They are shorter lasting and pain relieving, but temporary. So some people will have relief for like about 3 months, but they should use that relief to really work on the other more permanent measures like strengthening. Then the other kind of injection the orthopedic surgeons might give you are hyaluronic acid injections, which will inject this particular substance, which is like a gel inside the joint that will lubricate and protect the joint. Again, the benefit could last anywhere from 3 to 6 months, sometimes even less after repeated injections. They are good before you start a strengthening program, and they are also good if you want to postpone the need of surgery. So if somebody who has a end stage osteoarthritis, but the person is such that they are not physically capable of withstanding a major surgery like total knee replacement, then these injections could be of value because they will relieve them of the pain. And as it is, the person is not physically very active, being very frail. So the need of surgery is probably postponed. Then some of the surgical approaches, one of the approaches is knee arthroscopic surgery. Here, it is reserved for any kind of knee injuries. So if a younger person who has a normal knee, otherwise it is well aligned, develops a meniscal tear or develops a tear of the cruciate ligament, then um, arthroscopic knee surgery is recommended to clip that area of torn cartilage or repair anything. Or somebody older who still has a normally aligned knee, has mild osteoarthritis, but pain is there, and then there are some loose bodies inside the knee, which are like broken pieces of cartilage. So uh, they are good candidates for arthroscopy to remove the loose body. Or if they are in the early stages of arthritis, but they have a lot of pain and the cartilage is frayed and then there are some loose ends to it, so they can go in arthroscopically and shave the cartilage and make it more smooth. So then this surgery is of value in those kind of individuals. Then there is another surgery called the knee realignment surgery or the high tibial osteotomy. So in cases of varus or valgus deformity, when the alignment is altered, it could be in a younger patient with no other complications. You don't want to leave the person into that deformity, and then the risk of developing OA is very high. So then the doctors would recommend a high tibial osteotomy where they take out a wedge of bone and then they close the gap to straighten the knee. This is not really recommended for end stage osteoarthritis, so it is mostly reserved for younger people to prevent any future arthritis. In older adults, if they have a varus or a valgus deformity, then there is no need for a osteotomy, because if they do total knee replacement, while doing that, they correct the deformity and make the knee straight. Then The knee arthroplasty could be partial or complete. So the partial knee replacement is mostly done in unicompartmental arthritis, where the arthritis is limited to only one compartment. The other compartment is okay and the person is quite young. So this is less invasive and recovery is much faster. So this is a partial knee replacement done for those kind of patients. Not recommended for generalized OA. And then total knee replacement. So this is after all the conservative options are exhausted and there is no alternative. This is done to improve the quality of life, especially in older patients who are more than 70 years of age and have moderate to severe arthritis, and after all other options have been exhausted, they are still in pain and it's affecting their function significantly. They have a poor quality of life, and if a new knee will make them participate in more active things like being able to go out, climb stairs, and not be confined to the home, then that is recommended. Not really recommended for younger people because the life of the knee is maybe 15 years. I have seen in less active individuals up to 20 years that it could last. But after that, it comes loose and then they have to do it again. So this is mostly reserved for people in that age group. So one of the last approaches I'm going to talk about today is also called dry needling. This is one of the newest physical therapy pain management modality we use utilizing acupuncture needles. It is very effective in pain control, and we have used it successfully in knee arthritis with a lot of pain. But we reserve it as a breakthrough modality, meaning when we see that all other options are giving them limited relief and then there is some area in the knee that is not responding to the traditional approaches, then we will recommend this because it is not covered by the insurances. It is an out-of-pocket modality, but eventually it could get covered because it is really quite effective and there is a lot of research behind it. So in conclusion, knee osteoarthritis is a common and debilitating condition. Physical therapy will definitely reduce symptoms, improve function, control disability. So we have to target the instability in the knee, the weakness of the muscles, swelling, pain, poor alignment, and most importantly, engage in physical activity. It should be custom to each patient, and our goal is to slow the progression, improve function, and delay or not need the surgery at all. Thank you very much. So that concludes my summary of osteoarthritis of the knee, and we can have questions.
Yeah, thank you. Thank you very much. This was a very comprehensive presentation, and I'm sure people got a lot of information, but they have quite a few questions. So we are going to start with the question answer session. We'll start with the questions in the chat. Um, so do you want to stop sharing so we can see?
Oh, yeah.
Yeah. So there are quite a few questions about treatment. And so the first question is plasma treatment helpful?
Yes. PRP. It is called platelet-rich plasma. So they basically extract plasma from the person's own blood, and it is full of healing agents that our body naturally uses to heal. So platelet-rich plasma therapy is used for everything nowadays, like injections into the knee joint or into injured muscles or even for hair loss.
Hmm. There are a couple of questions about, are there clinical evidences on effectiveness of stem cell therapy?
Stem cell therapy, that's what I mentioned to you, is that they are doing research in NYU in their orthopedic department, where they are trying to see if they could regenerate the cartilage in the patient while they are suffering from osteoarthritis or at higher risk of osteoarthritis.
Okay. Someone has asked, is taking glucosamine chondroitin
Chondroitin, yeah.
chondroitin tablets effective?
Yeah, in early stages, very early stages of arthritis, where you are into the stage where um, the cartilage is not yet damaged. It's more of dryness in the joint. X-ray shows very minimal or no change, but the person has pain. So at that time, when you take collagen or when you take glucosamine, chondroitin, or MSM, then that helps the cartilage to hold more water. So that has been shown to be helpful. But it's not like a foolproof thing. It has to be, again, for any treatment, the patient selection is very important. It has to be for the right patient.
And one question which is self-explanatory is, do you have to get physician approval? So I guess it's yes for any and all treatment. So it's a general question for any of these things.
Yeah, some of these treatments, like for example, the PRP, you will need a doctor's prescription. For any kind of research, it will be led by the doctor. For physical therapy, you will need a doctor's prescription. But in the state of Virginia, we can provide direct access for up to 2 months. And then based on our assessment, then we can get the doctor to prescribe further.
Another question, what does it mean when your knees make a squeaking sound? Not always, but when walking, and what to do about it?
Yeah, so that's a sign of cartilage issue. So that is the drying of the cartilage. And if you feel any kind of cracks or squeaks or anything, if it is happening innocently, it doesn't matter. But if it is accompanied by pain, then you really need to get it checked out. But the knee joints are never like fully quiet. If you put your hand on them and move them, you will feel some like crackling or some sounds originating from there.
Next question.
And one more
yeah.
component to that answer. So the squeaking doesn't really is not very common in osteoarthritis, but it is more common in rheumatoid arthritis.
Okay, so they should talk to their doctor about that. Yeah. Are these arthritis symptoms also relevant to hip pain or spine degeneration?
Yeah, so arthritis is like a generalized condition where one joint may get affected more than the others. Common is the knee joint and the base of the thumb, but then hip is the next one. The lumbar spine and the cervical spine is also affected. So once you have one joint involved, then that changes your biomechanical loading in the entire body, and it starts affecting other areas. So even if you had arthritis in some other area, if it was quiet, now because of altered alignment, now that area will start hurting.
Okay, I think that goes with the next question. Is using treadmill bad for back pain or knees, and muscle cramps or knee issues, neck issues, lower back pain? Are they all connected in some way with the knee issues?
Yeah, everything is connected. Like if you have back pain, you will eventually get knee pain and vice versa. So treadmill is a very good exercise. The only thing is that you should be walking at a proper walking speed and not jogging or running on it. And then your goal is not to lean on the arms, let the arms swing normally. so that it will mimic your normal walk as close as possible. Because if you take arm support, then that changes your posture, and then you are not going to get the full benefit of walking. And then the other thing with the treadmill is that it is always inferior to walking on ground, because here in the treadmill, the ground is moving for you, whereas on the ground, you're propelling yourself. So you're using the muscle work is more. But if you cannot walk outside on some day, then you should use the treadmill.
Okay, yeah, that's really good information to know. Next question is, what would you recommend, bone building training or physical therapy?
So by bone building, what do you mean? Is it through medications?
So
No. तो मी बोलू का एक पटकन?
बोला.
नाही, बोन बिल्डिंग आता हे आहेत ना, बोन बिल्डिंग ट्रीटमेंट काउंटीज आहे किंवा प्रोग्राम असतात बोन बिल्डिंग, तर इज इट इम्पॉर्टंट और
Yeah. So
if
you go to a physical therapist and you tell them that you want to do general conditioning and strengthening, so that will be better than like a county offered bone building program, because those will be like some basic chair exercises or standing postures and positions. But the physical therapist will be using an approach targeted to your specific needs. It will be more individualized. So it's a good idea to learn from them and then do it at home.
Another question, there are a lot of questions related to physical therapy, but before that, I'll ask this about, are there any foods that are not good for OA? And what are some of the foods that are good for OA?
So Alka Deshpande would be the right person to answer that.
Yeah.
But I can only say one thing, that any kind of omega-3 fatty acids are always very good for our joints and cartilage and bone health, as well as vitamin D. So these two things are an absolute must: vitamin D supplementation and omega-3 fatty acids.
Okay. A question from Madhuri. She says, my father is 88 years old and had total knee replacement surgery about 13 years ago for one knee. He's active and now complains that his leg has no strength. Do you think knee braces will help him?
Yeah, absolutely. So especially when he is complaining of less knee strength, and if he's walking without any support, so then you don't want to wait till his knee buckles on him or he puts himself into any kind of risky situation. So physical therapy will definitely help him to look at what is going on. So what part of the knee strength is affected, or is it strength, or is it pain, or is it something else?
There are a few more questions. Do you recommend swimming and underwater exercises?
Yeah, swimming is of course one of the best general exercise for the body, and aquatic exercises that are offered through like the rec centers and through other organizations are helpful if you have difficulty moving on the land. That means because that relieves your body weight, it relieves the compressive forces on the joints, and it has a soothing effect on the muscles. So it is a low intensity but good strengthening exercise which is protective of the joints. Aquatics.
Okay. So we do have a few people who want to ask questions. We will give them a chance, but just one last question from the comments. How long is pre-op physical therapy recommended, and is it covered by insurance?
Yeah, it is covered by insurance, and it is a minimum of 4 weeks.
Okay. Asha Godse, Asha Tai, you have written, is helping walk with walker. So do you mean does walker help? And she says my age is 80.
Yeah, the walk depends on what kind of walker and how you are walking to begin with, and if you need it. So first of all, means you should really need the walker. Second, whether it is a 4-point walker or walker with 2 wheels or 4 wheels. So that's
four wheels.
4 wheels.
Ah.
So if a person has good walking, if the person has difficulty in walking due to poor balance, then the 4-wheel walker is the best, because that balances them, and then they can really pick up speed and walk normally and more distance without fear.
ओके. मी रोज एक राऊंड घेते. माझ्या उजव्या पायाला सर्जरी करायला सांगितलेली आहे. पण मी फिजिकल थेरपी करून असंच ते पुल ऑन करते, कारण मला ते जरा डिफिकल्ट वाटतंय.
अच्छा.
वॉकिंग सर्जरी करणं, कारण मला कुठं आता मॅरेथॉन करायचं नाही किंवा काय करायचं नाहीये. माझं एज पण पुष्कळ आहे. तर मी असं मनाला स्वतःला हे केलेलं आहे की ऍडजस्ट केले की आपण फिजिओथेरपी करूनच पुढे जायचं. इज दॅट गुड? इज दॅट गुड? माय थॉट इज
if it is
आणि
not,
मी एक्सरसाइज करते रोज माझा.
so if it is allowing you to do your function, if it is giving you pain relief and you are able to not limit yourself and do everything that you want, जर सगळं तुम्हाला करता येत असेल आणि जर तुमच्या सिम्पटम्स कंट्रोल होत असतील आणि तुम्ही स्ट्रेंथनिंग एक्सरसाइजेस करत असाल तर मग काहीच हरकत नाहीये. पण जर तुमचं पेन इतकं जास्त असेल की फिजिकल थेरपीने कंट्रोल नाही होत आहे आणि तुमचं फंक्शन कमी कमी होत चाललंय, जर डिक्लाइन असेल तर मग तुम्हाला मग अजून काही करावं लागेल. पण जर इफ यू आर मेंटेनिंग और इम्प्रूव्हिंग, देन दॅट्स फाईन.
थँक्यू. आता आपण लेट्स गो टू द क्वेश्चन्स. सो वी हॅव प्रकाश.
एक मिनिट, आय हॅव टू गो. मी जरा पुढलं हे इंट्रोड्यूस करून जाऊ, चालेल का?
अनघाताई मी सांगते, यांचं झाले प्रश्न की मी सांगते लास्ट.
मला जायला पाहिजे म्हणून.
ओके,
असं क्विकली. मी पटकन बरं. पुढला पहिला म्हणजे इतके छान प्रश्न आहेत, सगळ्यांना तुम्ही फार सुंदर उत्तर दिली आहेत. थँक्यू व्हेरी मच फॉर दॅट. इतकी तुमची प्रेझेंटेशन स्टाईल फार छान आहे, अतिशय. आणि स्लाइड्स ऑल्सो. जनरली कधी मी स्लाइड्स बघत नाही पुन्हा नंतर, पण ह्या वेळेला नक्की बघणार आहे. फार छान, व्हेरी इफेक्टिव्ह, व्हेरी युजफुल.
थँक्यू.
आणि पुन्हा आम्ही नक्की बोलू तुम्हाला, आणि तुम्हाला वेळ असेल तर प्लीज या, कारण देर आर सो मेनी अदर क्वेश्चन्स विल हॅव फॉर अदर इश्यूज. आणि दुसरं पटकन सांगते, नेक्स्ट प्रोग्राम इज अलका देशपांडेचा आहे आणि होम रेमेडीज फॉर जनरल एलिमेंट्स. तर तुम्हाला आता ह्याच्यातनं अनेक प्रश्न आले असतील, ते सगळे तुम्ही तिला विचारू शकता. आणि तुम्हाला माहिती आहे तिचं किती छान उत्तर असतात, तिचा किती चांगला अभ्यास आहे. तेव्हा जरूर नेक्स्ट वीक या. ओके,
थँक्यू.
थँक्यू.
I had to go. I'm sorry. I have some guests at home. Yeah. Okay.
थँक्यू. ओके, प्रकाश.
मी अलका बोलतेय. प्रकाश नाही, प्रकाशचं नाव आहे त्याच्यावर. पण मला आहे मल्टिपल जॉईंट्स, म्हणजे दोन्ही शोल्डर्स, पायाचे अँकल्स. सो इतक्या सगळ्या सर्जरी करणं शक्यच नाहीये. सो व्हॉट इज द कोर्स ऑफ ऍक्शन? मी रेग्युलर एक्सरसाइजेस करते, स्ट्रेचिंग करते, फिजिकल थेरपी केली होती, पण पेन इज स्टिल देअर.
So you have to see where is the most pain. सगळ्यात जास्त तुम्हाला कशामुळे त्रास होतो?
आता सध्या शोल्डर दुखतोय माझा, लेफ्ट शोल्डर, विच वॉज रिपेअर्ड. टेअर झालं होतं. सो दे रिपेअर्ड द टेअर 2009 मध्ये. आता इट इज स्टिल, आता खूप पेन होत आहे मला त्याच्यामध्ये.
अच्छा. सो द थिंग इज लाईक तुम्हाला जिथं सगळ्यात जास्त त्रास असेल त्याच्यावर सगळ्यात जास्त अटेन्शन देणं जरुरी आहे. आणि जर तुम्हाला सर्जरीचं डिसिजन घ्यायचं असेल तर दॅट शुड बी द फॅक्टर that should make you think that, okay, if I do this surgery first, will that make a big difference in my life? Can I deal with the other things then on my own? कारण एखादा जॉईंट असा असेल की ज्याच्यामुळे तुम्हाला खूप त्रास होतो, तेवढा जर तुम्ही अटेंड केला तर मग बाकीचे मॅनेजेबल आहेत का?
म्हणजे आय शुड रिली टॉक टू द ऑर्थोपेडिक माणसाशी बोलायला पाहिजे की कारण मला कोणतरी सांगितलं की शोल्डर्स हॅव टू बी स्ट्रॉंग बिफोर यू डू नी सर्जरी. इज दॅट राईट?
हो, कारण तुम्हाला वॉकर वापरावं लागेल, केन वापरावी लागेल.
So I
तर
need to do.
हातावरती थोडं जर तुम्ही दोन्हींनी एकत्र कराल तर खूप जास्त डिपेंडन्स तुमच्या अपर बॉडीवर राहील.
Oh,
तर it will be really hard on your shoulders if you do both knees together. So that
so
you should not do.
probably address the shoulders first. And then
So address the most painful shoulder first, which is your dominant side, whether it is right or left.
Okay. Okay. Thank you.
Okay. Next, Suchita.
Hi, I'm Suchita Kulkarni Lamur, Pittsburghla, and I'm also a physical therapist. And your presentation was absolutely fantastic, comprehensive, thorough. If you are my student, you'll get an A+++.
Thank you.
माझे दोन प्रश्न आहेत आणि in the sense of time मी दोन्ही एकदम विचारते. तर the very first part of your presentation, you said something about the prevalence of osteoarthritis in India is higher. तर ते तिथे आणि बरेच लोक ती लाईफस्टाईल किंवा सिटिंग ऑन द ग्राउंड किंवा योगा पोझिशन्स इथे वापरतात. म्हणजे इज देअर समथिंग टू डू विथ sitting cross-legged for too long or sitting in yoga positions for too long or doing too much of that? Is there any research on that?
If you assume a position like after the age of about 45, 50, if you assume like a deep knee bent position for too long, and then you try to get out of it suddenly and suddenly start moving, that's when a lot of injuries happen. I have come across many patients of our culture who said that I was sitting in the temple with cross-legged for a very long time, or I was sitting with my knees bent backwards in a masjid for a very long time, and then suddenly started to get up and walk, and I felt a crack in the knee, and then they developed like a meniscal tear or something. So it could have been something that was already happening slowly, and then that precipitated. So, and then even in arthritis, if somebody has osteoarthritis, if they maintain one position of the knee for too long, then that usually causes more stiffness, and they are not ready to really just start walking at their usual speed as soon as they get up. So that causes more dryness and more focal loading of that part of the cartilage.
So is there any specific time ki dar 20-25 मिनिटांनी तुम्ही
Like about 20 minutes.
Okay, so that would be ideal.
Yeah, so change of position or movement.
Right. And my second question was about how much exercise is too much exercise, weight bearing exercise.
So you have to really start very slowly and then make changes or progress only weekly. So there is no one particular amount of what is too much. So I would suggest that it is always best to start first with walking and then slowly start with exercises of gentle stretches in supine, that is lying on your back, and in prone. And then once you are able to tolerate that for a few weeks, then slowly add maybe bicycling, stationary bicycle, or some resistance exercises to the legs. So that's how you have to go slowly. But if you have a lot of pain to begin with, then you have to first at least get the pain to a manageable level before you start exercising, because then it will suddenly trigger the pain and you may have more difficulty from the exercises.
Yeah, actually my question was directed towards people who are in the preventive mode, who are not in, त्यांना काही दुखत नाहीये, अजूनपर्यंत काही झालेलं नाहीये, आणि they are exercising. Are they exercising too much by doing 2 hours a day, or is that?
Yeah, you have to start with at least 20 minutes of exercise a day first. And then after 1 week, like, because it will take you up to 1 week to realize how it is affecting your body, if you're getting any pains or strains. So start with the easiest of exercises for 20 minutes a day if you are starting from scratch, and then build on it.
Okay.
Because I see a lot of people who suddenly start going back to the gym, and then they want to start at the level where they left off. And that's when they get hurt. So if you want to go back to the gym, then first engage in exercises such as bicycling or treadmill, and then any kind of exercises with weights that involve pulling rather than pushing. And then the last thing that you should introduce is pushing overhead. Any kind of pushing overhead activities cause the most injuries to the shoulder. So you have to protect your shoulder when you're doing your weight exercises, and protect your back when you're doing any kind of weight exercises. So the way to protect the shoulder is avoid anything lifting overhead in the first couple of months of exercises. So you can start with pulling type of exercises or pulling down, pulling towards you, then slowly move on to pushing type of exercises, but no pushing up for a couple of months. Then you can do leg press, you can do leg extensions a little bit, and then start the dumbbells with very small weight. And then once you're used to all of that, then you can do the shoulder exercises. Because if the shoulder gets hurt, that is the hardest area to get relief. It could take like 6 months to a year before the shoulder gets better.
Wow. Yeah, thank you, Suchita, for that question. And thank you for this wonderful answer. We will take last two questions because we are almost out of time. So, Nisha.
येस थँक्यू. माझं नाव निशा करंबेळकर, मी बॉस्टन वरून बोलतेय. फार चांगलं प्रेझेंटेशन, युजफुल माहिती मिळतेय. या जस्ट क्विक क्वेश्चन, मेनिस्कस टेअर इज दॅट रिव्हर्सिबल? मला झालं 4-1 वर्षांपूर्वी. आय एम मच बेटर, but I'm just hoping whether it will be reversible at all ever or not.
Yeah, so there are various kinds of tears. Sometimes there is a very small tear in the body of the meniscus which is not separated, and otherwise the meniscus is healthy. There could be a very small tear, and then if you take good care of it, do therapy, it will take time, but it will heal in place. But if that tear is like a bucket handle tear, that is like the outer ring of the meniscus is separated, or if there is a loose end to it, if a piece, one end of the meniscus is loose, like of the tear piece is loose, then that will not heal. Anything that shows a gap, or if it is torn in place but there is a gap in between, then it will not heal. So then you will need arthroscopy to get taken care of that, because if it gets pinched in between the knee, then it will cause very severe pain and then arthritis eventually. So if somebody has a brand new tear, MRI was done, it shows a very small tear, and then if their knee is fully straight, or after a couple of weeks they can fully straighten the knee, that's a good sign. But if the knee does not straighten fully and stays bent, that means there is something blocking full extension, which is the part of the meniscus. So those people eventually will require surgery. But once that surgery is done, earlier it is done, the better. And then you will have a deficient meniscus, but you can have a pain-free knee.
Okay. Thank you very much.
Yeah, Rekha Devdar, do you have a question?
मला वाटतं इथे सगळे मराठीत आहेत, त्यामुळे मराठी बोलणार आहे. माझ्या प्रश्नापेक्षा मला तुम्हाला एक महत्वाची गोष्ट सांगायची आहे. माझ्याकडे माझ्या सासूबाई मागचे 36 वर्ष राहतात. आता त्या 101 वर्षाच्या आहेत.
वाव.
त्यांना अजूनही कधीही नी पेन वगैरे काहीही झालेलं नाहीये. त्या इथे आल्यानंतर, तेव्हा आल्या तेव्हा मला वाटतं 64-65 वर्षाच्या होत्या. त्यांना इंग्लिश अजिबात येत नाही. त्यांना मी टीव्हीवरचा सिट अँड बी फिट हा शो त्यांना लावून देत होते, आणि तो त्या अगदी नियमाने करायच्या, एक दिवसही न विसरता, आणि बाहेर फिरायला जायची. एवढ्या 2 गोष्टी त्या अगदी आतापर्यंत केल्या. म्हणजे मी खरं सांगायचं तर त्या आता 5 ते 6 वर्ष झाली वॉकर वापरायला लागल्यात. नाही तर अजिबात वॉकर पण वापरायच्या नाहीत. अजूनही लंच आणि डिनरला त्या वरनं खाली येतात आणि आम्ही हात धरायचा नाही, त्या जिन्याला धरून खाली येतात. की आल्या खाली की जेवतात, मग एक 5-6 फेऱ्या घरातल्या घरात मारतात आणि मग परत वर जातात. औषध म्हटलं तर त्यांना म्हणजे डायबिटीसचं आहे, कोलेस्ट्रॉलचं आहे, ब्लड प्रेशरचं आहे, व व्यवस्थित गोड खातात. आता आम्ही काही त्यांना काही म्हणत नाही खाऊ नका वगैरे. एकच मात्र त्यांनी केलं की त्यांनी ऑलमोस्ट इथे आल्यापासून बरेच वर्ष फॉसोमॅक्स घेतलं.
अच्छा.
तर तेव्हापासून म्हणजे त्या कधीही पडल्या नाहीत, बॅलन्स गेला असं म्हणून. त्यांचं कधीही काही कुठेही फ्रॅक्चर झालं नाही, नॉक ऑन वूड, आमचं नशीब. पण म्हणजे सांगते की हे म्हणजे बोन डेन्सिटी चांगली राहिल्यामुळे त्यांना नी प्रॉब्लेम वगैरे आला नाही का, असा माझा प्रश्न होता.
नाही तर जनरली काय असतं की जे काही व्हायचं असतं ते बाय एज 85 पुष्कळांना होऊन जातं. 85 नंतर मी जे सिनियर्स बघतो, जनरली इट इज स्मूथ सेलिंग as long as they have a regular routine, they eat in a very measured way, and they do not fall. So of course there are good genetics, then there is good care from the caregivers, there is good quality food, there is exercise, all of these matter. पण त्या एज ग्रुप मध्ये न पडणे, दिस इज नंबर 1. काय वाटेल तर झालं तरी पडायला नको. आणि जे सेफ असतं, म्हणजे जे असे ज्यांचं रुटीन चांगलं असतं आणि जे सेफ्टी आपली घरामध्ये ठेवतात आणि जास्त खाण्यापिण्याकडे त्यांचं बरोबर लक्ष असतं, काही त्यांना त्रास नाही होत. म्हणजे पण गॉड ब्लेस हर, like despite having issues with bone density and despite having all the 3 conditions of diabetes, blood pressure, and cholesterol, and properly managing them. So credit goes to her and also to you to giving her that kind of an environment where she could maintain that lifestyle, that encouragement, and the family support. So that is also very critical, like to have like a very stable family support and companionship. So that also makes a difference. So it's a multifactorial thing. The longevity is not dependent on just one thing. But to answer your question, it is not just the bone density.
Okay.
What is the show you said? What is the show?
Yeah, मला वाटतं we can add one more factor to that. She has no stress.
Yeah.
She has no stress at all.
थँक्यू सो मच. मला वाटतं ह्या पॉझिटिव्ह नोटवर, आणि थँक्यू सो मच रेखा देवधर आमच्याशी शेअर केल्याबद्दल. खूपच इन्स्पायरिंग स्टोरी आहे आणि या पॉझिटिव्ह नोटवर आपण हा कार्यक्रम थांबूया. वी आर ऑलरेडी ओव्हर टाइम. आणि आय वॉन्ट टू रिअली थँक यू डॉक्टर विभाकर फॉर गिव्हिंग अस सच व्हॅल्युएबल इन्फॉर्मेशन. आणि people are asking, is it okay if you share your contact information? So if you want to, you can put
Sure.
in the chat box your email or phone number, however you want to answer more questions.
Yeah.
And yeah, so after
what is the TV show, she said?